name is Estella Lugo. I am the moderator for CMT Connect webinar series for the Hereditary Neuropathy Foundation. And tonight's webinar is on a very important topic, family planning. So this is going to be a three-part series. Tonight is part one, which is going to be focusing on IVF. And we have two very experienced and fantastic genetic counselors. First, we're going to hear from Tara Jones, who is a genetic counselor at Cedar-Sinai. She's going to give us a presentation, and then we're going to have some time after her presentation for some Q&A. And then we're going to hear from Laura Rust, who is a genetic counselor at Mayo Clinic. So everyone will have time to ask their questions. And once Laura is done, we'll circle back and answer some more questions. And if for any reason we're not able to answer your question, or you still have additional questions after the webinar, please email us. At the very top of the chat window, you'll see your email address, which is info@hnf-cure.org. That will reach either myself or Courtney, and we'll make sure to connect you with the correct information. So without further ado, I'd like to welcome first Tara Jones, and to share a little bit about this presentation for family planning. Thanks so much for joining us, Tara.
Of course, thank you so much for the invite. I see a couple of familiar names in the audience, so thank you for joining. I work at Cedar-Sinai in adult neurology and am part of our CMT clinic. I've been here for a little over 3.5 years, and I would have to say that CMT has kind of become my favorite genetic disorder. I get to hear all of our patients' stories and really appreciate everyone's vulnerabilities and strength and courage going through their disease course. So I am titling my talk The Practical Guide to CMT Genetics because I am sure a lot of you have already had genetics talks about CMT. Our objectives will be to understand the naming schema of CMT, to learn or refresh yourself on the basics of genetics, assess the meaning of your genetic test results, and understand what is meant by a clinical versus genetic diagnosis. And finally, the purpose of this entire series is to know your family planning options. So we can't talk about CMT without showing Charcot-Marie and Tooth, right place at the right time. They happened to connect with one another through their studies and mentorships. And that is where CMT gets its name, after these three physician scientists. Okay, so the nomenclature for CMT is based off of pathology and inheritance pattern. So this is a picture of a neuron. I kind of liken this to the brain of the neuron with the nucleus, and these are the feelers of the neuron. And so it's just transmitting messages back and forth. When someone feels something hot, it tells the brain that it's hot and you should remove your hands, things like that. The purple wire that connects the two is called the axon. And the yellow sheath around it, we kind of call this like the rubber coating around a wire, is the myelin sheath. And so when we hear CMT type 1, we are talking about demyelinating CMT. And when we hear type 2, we're talking about axonal. And then modes of inheritance. So dominant would mean that you would have 2 copies of those genes, and only one copy would need to be broken to cause disease. X-linked is where women have two X's, men only have one X and a Y. And so that just means that the specific gene that causes that CMT is on the X chromosome. We tend to see males be more severely affected and have similar presentations. However, females are all over the place because they have an additional X chromosome and a working copy of that gene. And then finally, we have Cmt Type 4, which is recessively inherited. And that means that of those two copies, both copies need to be broken to cause disease. And with CMTX, we tend to have demyelinating or intermediate pathology. So that would be during the nerve conduction study, intermediate would be kind of in between demyelinating and axonal. And then with CMT type 4, we can have either demyelinating or axonal features. Okay, so the genetics of CMT are quite vast, and you can see that some genes overlap. MPZ, myelin protein 0, is actually my favorite gene because it can cause 3 different clinical pictures of CMT. So it can cause type 2, it can cause type 1. Of the type 1, it can be severe early onset or more mild adult onset. HMN is hereditary motor neuropathy. So under the CMT umbrella, but this has motor features rather than sensory features. So the motor neurons are the ones that innervate the muscles and tell the muscles when to constrict and relax and work appropriately. So key features of hereditary motor neuropathy might be weakness, whereas hereditary sensory neuropathy tends to not have any weakness, but major sensory issues. So people might have extreme pain, a lot of numbness and tingling in their hands and feet, and little to no weakness. And these are all dominantly inherited causes of CMT. And you can see here 7q34, that is a locus that's been identified. So they've kind of tracked it through disease in families, but they haven't identified the genetic cause. And this paper is from 2019, so relatively up to date. Okay, whoops. And the recessive genetics of CMT are also quite vast and also overlap as well. So going on to the genetics piece, so we're going back to the basics. Believe it or not, this is the least complicated picture I've been able to find of the central dogma, which is DNA to RNA to protein. I think of our DNA as your grandmother's cookbook. It is an heirloom, and you don't want to mess it up when you're cooking in the kitchen. So you take a copy of one of her recipes, and you bring that to the kitchen, and that is what our RNA is. Then, as you can see here, these green parts here called the introns are actually taken out and spliced together to just be exons. And from RNA, that now becomes mRNA. And I call that your modern touch to the recipe. So let's say that you don't have eggs and you're going to use applesauce instead. But let's say that the recipe card got a little bit smudged when you were copying it, and you read that you need to add a brick to your cake, and you can't actually make an edible cake out of that. So that's where some of these alterations can be beneficial or harmful. And then finally, our protein is the final cake. So that's kind of what we're talking about when there's a genetic mutation in the gene at the DNA level that can lead to an abnormal protein, or sometimes not even a protein at all. And when we talk about these genetic alterations, we might call them mutations. Today, the new nomenclature is a pathogenic variant, but either way, mutation or pathogenic variant typically means that it is disease causing. And the genetic code is written in 3-letter words. So with this simple sentence, if you make one change and just change the letter, you can have a sentence that doesn't make sense anymore. As well as adding a B right here in the sentence shifts the whole sentence over, and none of the words past the B make sense. A deletion of the A also causes an ineligible or illegible sentence, and a deletion makes the sentence not make any sense. So that's what we mean when we have these genetic changes that cause harm. Okay. The computer is slowing down. Hopefully that's not forthcoming. So we might have a pathogenic variant that we described in the previous slide, but here I want to kind of focus on these uncertain variants, because the more genes we have on a panel, the more people we test. The uncertain variants that come out on the test report become more frequent, and that's job security for me. But it basically means that we haven't seen this genetic change or spelling change in the general population to know if it's causing the gene to not work right or if it's just a unique difference. So going back to that cake analogy, are you replacing eggs with applesauce or bricks? And then if you do have an uncertain finding, it makes a lot of sense to make sure that you have it interpreted by a genetics professional. And when we take a look at those reports, we're looking at, does it match with your symptoms? Does the inheritance pattern make sense? Could there be other relatives we could test to see if we can get more clues about this? And is it close to a known pathogenic variant in the gene? So a lot of times if things are just a couple nucleotides or letters off, we know that there's a higher chance for it to be in a mutational hotspot. As well, we might have the terms on our report likely pathogenic or likely benign. And that means that we're not yet sure if it's pathogenic or benign, but from this uncertain realm, it's kind of steering towards that. In many cases, we treat likely pathogenics as pathogenic, but we have learned that sometimes those variants get downgraded to be likely benign. And so it's important to really weigh that in for any clinical decisions. But with CMT, we're not really changing management based off of these results. All right, so understanding how to read a genetic report. Your report is going to look different depending on what lab did the testing, but we will basically have the classification that the lab made, the name of the gene, the location on the DNA, and the specific protein change or final cake that comes out of it. And so in this first line, we have something pathogenic in the gene MFN2. That stands for mitofusin 2, which is the cause of CMT2A. And here we have a C dot nomenclature indicating that at position 281, where we should have a G, this person has an A. And what happens with the protein is what should be an arginine, the building block of protein, at position 94 is actually a glutamate. And so having this amino acid in place of the arginine is enough to cause the gene to not work properly and cause disease. Whereas uncertain findings, this one happens to be an ATL3 atlantin 3. And again, here's our C dot nomenclature and our P dot nomenclature indicating DNA level and protein level. So we will go through an example of an answer that's very clear on a report. So it's not in the order that I just presented on the slides, but it has the same information. So it's giving us our gene name, MFN2. It's telling us the C dot nomenclature. It's telling us the P dot nomenclature. It's telling us that it is pathogenic. So this is not likely pathogenic. This is a known, well-documented mutation. And zygosity is saying heterozygous. And hetero basically means that when you have two copies, one of them is different. And that specific genetic change is only on one copy of the gene. When you see homozygous, it means the same change is on both copies of the gene. And then when you see hemizygous, that is referring to X-linked, where men only have one X chromosome, so there's no way to have a second copy of that gene anyways. I should say males typically only have one X chromosome. So this leads to a diagnosis of CMT2A. Here is a clear answer, but we need to pay closer attention. So here we have PMP22, which many of you are aware of, causes CMT1A. Heterozygous, so just one copy has this change. It is pathogenic, but this is a deletion rather than a duplication. So when we have an extra copy of PMP22, so 3 copies total, that causes CMT1A. But when we have a deletion, that means that you have only one copy of the gene, and that causes HNPP, which is hereditary neuropathy with liability to pressure palsies. So if you were to sit down for a long period of time and your butt kind of falls asleep, those are the pressure palsies, but with HNPP that might last longer and might never go away. So this is a huge distinction between CMT1A, and you'll want to make sure that you look at that report very closely because it's a big difference on which condition you have. And finally, we have a likely answer. So in this case, the MPZ gene is likely pathogenic. And this patient also has 2 uncertain findings in 2 different genes. Now, when I took a look at this patient's history, we saw that they actually had axonal CMT, so CMT type 2, and their father had the same CMT type. So we ended up testing dad. We ended up testing an unaffected aunt on dad's side. And dad had the MPZ variant, but the aunt did not. And a year later, the lab actually reclassified this as likely pathogenic, where it was uncertain at first. So we can say that this is basically the cause of the patient's CMT, but like I said, that might get reclassified later, and not until they actually study the variant in the lab will they ever be able to truly reclassify it as pathogenic with no question about it. And so this patient likely has CMT2I caused by myelin protein 0. So if you don't have a genetic answer, if you're not one of those last 3 cases that I presented, do you still have CMT? And truth is, some people are told their whole lives they have CMT. When they come to one of the centers of excellence for CMT, they learn that it's not that. And so that's why I always recommend, if you've been told by outside neurologists, make sure you go to a specialist who sees CMT very often. And you'll be able to find out if you are of the camp that has a clinical diagnosis of CMT, but no genetic diagnosis, or if you've just kind of been misdiagnosed as having CMT. And so this chart is exemplifying the number of patients that are tested that don't have an identified genetic cause. So this was a study at University of Iowa and UCL Queen in London. And out of 220 patients with CMT, and they had clinical diagnoses of that, only 30% had a genetic diagnosis. And we know that CMT type 1, the demyelinating type, has the highest chance of finding a genetic cause. A majority of those will be CMT1A. Axonal CMT, not so much, and even less with hereditary motor neuropathy and hereditary sensory neuropathy. So all of these people that are in the red have a clinical diagnosis of CMT, but we just haven't found the genetic cause as of yet. And unfortunately, in those cases, there's a lot more limited choices in family planning when we have no genetic answer. And so these choices in family planning, when we know the familial variants, have an asterisk next to them. So one can choose to conceive naturally and test the pregnancy prenatally to find out whether or not they have inherited CMT. Some people choose to terminate the pregnancy if it tests positive. If you're not planning on changing the outcomes of the pregnancy, it's typically recommended not to test prenatally and wait and see if your child grows up to start having symptoms. We can have egg, sperm, or mitochondrial donation. So if the woman is the one with CMT and they don't want to pass it down, they can use an egg donor. If someone has a mitochondrial cause of CMT that affects the mitochondrial DNA, you can actually get a N-nucleated egg donated. So that would include your nuclear DNA, but have mitochondria from another person. And that's pretty confusing. I can explain it if anyone has questions afterwards. And then third, which we're going to cover today, is in vitro fertilization with pre-implantation genetic diagnosis or genetic testing. And Laura is actually going to go into a lot of detail about this, so I won't even touch on that. Of course, we can consider adoption. And for some people, they want to have their own biological children, and that's just not an option for them. And finally, surrogacy, typically for females who have CMT and are afraid of what pregnancy might do to their bodies, and possibly make their CMT worse. And that's actually a topic that we will cover in, I think, the third part of this webinar series. And so the asterisks are what is available if the genetic variant is known. These other options, egg and sperm and mitochondrial donation and adoption, will be available to anyone. Okay, and these are my references. My email and phone number is at the bottom here. I'm happy to take any questions, and I apologize for the sound of my dog snoring.
No worries. Thank you, Tara. We had some comments that people were entertained by it. So no worries. Yeah, would you, while we wait for some questions to come, can you go a little bit deeper into the mitochondrial implantation? Because that's the first time I personally heard about that, and it seems really, really interesting. What's the difference between that and sperm or egg donor? And does it carry the same characteristics of the parent?
Right, so we have basically two different sets of DNA. We have our nuclear DNA that came from mom and dad, and then our mitochondrial DNA are within the mitochondria of the cell. So they're outside of the nucleus, and those are inherited solely from our mother. And so we know that a male with mitochondrial disease can't pass that down to children if it's caused by a mutation in the mitochondrial DNA. But for women, they can potentially pass down that mitochondrial mutation to sons or daughters. And so what they basically do is they still harvest eggs, and they'll actually pluck away the nucleus from the donor egg and insert the nucleus of the person with CMT, so that the child will have their nuclear DNA but mitochondrial DNA from another person.
Okay. Yeah, I mean, that sounds, is that something that's, how long has that process been available? Is that newer?
I think about 5 years, and it's commonly used for people with mitochondrial disease. Sometimes we don't think of CMT as being mitochondrial, but we know that there are some mitochondrial DNA mutations that can cause some rare types of CMT.
Okay, and that's something genetic counselor would be able to decipher from the genetic report.
Right, yeah.
Okay.
And unfortunately, to find a mitochondrial mutation can be a lot of work and a lot of money. Right. But if we do find it, we know what we're working with, and that would be an option.
Right. Okay, we had a comment here from Caitlin. She's going to try and explain this to the best of her ability. Well, we are recording the webinar, so that will be available early next week. So hopefully you can watch, your husband can watch the webinar. They're going to do IVF Genetic Testing. And she said if all goes well with that process, we will have children without CMT 100% removed from their DNA, so it doesn't continue on to the children. And so she has CMTX, HMSN.
So that's a good question. And with genetics, we never really use the words 100% or guaranteed. But when the pregnancy or when the growing blastocyst gets tested and doesn't have that mutation, that's very reassuring, but there's a possibility that some of the cells in that blastocyst, so usually they'll get to like an 8-cell stage and they'll pluck a single cell from it. Perhaps some of those cells still have the mutation. So sometimes families choose to confirm with prenatal testing to be even more reassured that the child did not inherit that mutation.
Would it affect the severity if there was still a small trace in some of the cells, or could it still manifest into the same level of symptoms? Or
so that the phenomenon is called mosaicism, kind of like a tile mosaic where not every tile is the same.
right.
And so it kind of depends on what stage that embryo split off. And so that'll kind of tell you, or that will predict, the number of cells in the body that do have the mutation and whether those cells happen to be nerve cells or muscle cells, or whether they are brain cells, heart cells. That can become very varied. And that's one of the reasons why females with CMTX have a really different presentation between each other, because some of those cells will be activated and others won't have that X chromosome activated.
Gotcha. We have another question here that just came in from Lauren, a good childhood friend of mine. She has CMT2K, GDAP1, ATL1 variant. Her daughter is positive, but does not have the ATL variant part, only the GDAP. What does that mean? Is there a difference if you don't have the variant of questionable significance? She's doing IVF with PGD soon.
So I trust that your daughter is meeting with a genetics professional who can take a look at their report. In most cases, if we have a pathogenic finding or a likely pathogenic finding and it explains the family history and the clinical picture, we can say that's the cause. And this uncertain variant, we can kind of brush under the rug. In most cases, we kind of disregard those uncertain findings. We might find out in the future that 2 different genes combined will change someone's clinical picture if then someone who just had the single finding, where it's digenic inheritance, where kind of 2 different genetic mutations on different genes can collectively cause disease. But chances are, if you have GDAP1 and your daughter also has CMT and inherited the GDAP1 gene or variant, then I would say that's the one that they should be worried about or concerned about with IVF.
Okay. Just trying to think. Try and get. Lauren, did you have any follow-up questions? Would you like me to turn your mic on? Feel free to speak. Because as I remember, both your daughters don't show any CMT symptoms, correct?
No. And my youngest daughter, just tested positive and we were shocked. But they told us that she didn't have the ATL part, so I can have the ATL and she could not? Is that how it goes?
Yeah, and GDAP1 actually has both dominant and recessive inheritance. So it'll be important to speak with a genetics provider who can look at that specific GDAP1 variant to see if it is only associated with dominant inheritance or recessive.
Oh,
and then
okay. I'm
that
dominant.
might tell us it's ATL1 in you, and therefore daughters don't have it. So
Okay,
Yeah,
so it
I'd
is
say
possible-
make sure
so it is
someone takes a look at
possible.
those reports.
It's possible for someone to have one without the other, is what I'm saying.
Yes, yeah.
Okay.
As long as the genes are, far apart from each other, there's a rare chance that they will always be inherited together.
Gotcha. Thank you so much.
No problem, Lauren. Thank you. Caitlin, did you have any follow-up questions?
I don't know. Thank you, though.
No worries. Appreciate it. Okay. I had another question regarding the costs involved. I'm not sure if this is something that Laura, you plan on diving into, or Tara. Yes. Okay. So Laura will go into that a little bit. I know that's usually one of the top questions on everybody's mind, that obviously this is not a cheap process, but for a lot of people, well worth it. So, all right. Well, thank you so much, Tara. And we will turn the mic over to Laura, who's going to have a presentation for us as well. And of course, we will have some time for follow-up questions.
Sounds
Thank
great.
you,
You can go.
Sure, but she's staring into the sun.
all right.
Sorry, I'm just trying to make sure I have all my screens. I have multiple screens here, so
No worries.
bear with me here.
I usually have about 60 or so tabs open at the same time.
Yes,
So,
all right. Are my slides showing up for you? Perfect. All right. I've somehow lost the Zoom stuff, but that's okay. As long as you can hear me and see my slides, I think we're good. So, okay, well, thank you everyone for having me today to discuss a little bit about some of the family planning options. My specialty as a genetic counselor is really in reproductive genetics rather than in specifically in CMT. So I see patients with all sorts of genetic diagnoses to discuss some of the family planning options that I'm excited to share with you today. So just thinking about what is family planning, the dictionary definition really talks a lot about, I copied this from a dictionary, the practice of controlling the number of children in a family and the intervals between their births, particularly by the means of artificial conception or voluntary sterilization. And that really is kind of a limited definition. It's really focusing on people that really just like contraception. Rather than, I think it's important to expand this definition of family planning to include people who want to know more about risks of particular genetic conditions, understand what those risks are, and then potentially consider options for lowering that risk in their children. There are multiple different points when we see patients in reproductive genetics. In the preconception setting, sometimes we just talk about what is that risk, understanding that risk. And for some people, they just want to know, is it a 25% chance? Is it a 50% chance? Is it something like with X-linked inheritance where it would maybe affect a male more frequently than a female, and just feel comfortable knowing a little bit about what that risk looks like. Sometimes carrier testing is involved, especially for recessively inherited conditions or recessive forms of CMT, where we're testing parents who are asymptomatic to see if or confirm that they are a carrier of CMT or potentially other recessively inherited conditions. There are recommendations to do carrier screening for a lot of different genetic disorders that sometimes can seem like they go hidden in families. So sometimes it involves testing for more things if those families are interested in that. At conception, and kind of what we'll focus on today, is pre-implantation genetic testing, formerly called pre-implantation genetic diagnosis. I think around 2017, some groups decided to change the name on us. So officially we call it pre-implantation genetic testing, or PGT for short, but we still use PGD interchangeably with this type of genetic Testing. And this is testing that is done on an embryo that is created through in vitro fertilization. And as Tara mentioned, there are options of doing prenatal testing during a pregnancy, testing a placental sample through a procedure called a chorionic villi sampling, or an amniocentesis, or testing after delivery. And sometimes this is to make decisions about pregnancy management, or potentially just considering delivery locations, preparation, and different things like that. So again, the focus today really being on in vitro fertilization and pre-implantation genetic testing. I'm going to share a little bit about in vitro fertilization, kind of a high-level overview of IVF. Certainly, I am not a doctor, I'm not a reproductive endocrinologist, and so if you do get to the point of doing in vitro fertilization, you'll probably get even more details than what I am providing today. But I think it's a good overview to know a little bit about the timeline, the cost, what might all be involved in vitro fertilization, as well as in genetic testing. So first, starting with just the IVF process. So this picture is just a simplified view of that IVF process, and kind of a timeline of events here. So to start, to do IVF, you have to be a good candidate for IVF. And that would mean for females having a good ovarian reserve, making sure you have a good number of eggs that would be able to be retrieved through a surgery. For men, making sure that there's no issues with sperm count or quality or things like that. And so there's kind of this process of undergoing a bunch of different tests and ultrasounds and making sure that you're a good candidate there. And then moving on to the actual process of ovarian stimulation, egg retrieval, sperm retrieval, the actual IVF process, growing those embryos, and then transferring those embryos, hopefully for a pregnancy. This view here is quite a simplified version. It is quite a bit more complex than that. This I've copied from some of our patient education at Mayo Clinic. Every clinic is going to be just a little bit different, but overall, there are a lot of steps in just this first part, just the step one, the test and diagnosis piece. And that's including for females having certain hormones tested on certain days of your menstrual cycle, infectious disease testing, ultrasounds of your uterus and ovaries, meeting with specialty consults, including genetic counselors. We have people meet with our business office to kind of understand the financial pieces of everything. Men need to have a semen analysis. And then there's a bunch of different appointments that are done. And so it actually is a pretty long process before you can actually even get to that point of being approved to start IVF. In general, that timeline for this first part, this test and diagnosis step, is generally around 2 to 3 months. And that's kind of best case scenario if you're aligning appointments at the perfect time and not hitting holidays and vacations and things with your schedule. And so it sometimes can even take longer than that. The next steps are kind of all somewhat simultaneous. So once you're approved to start the IVF process, you do, for a female partner, would do an ovarian stimulation. And this is normally on a menstrual cycle, women will ovulate only one egg at a time. And with IVF, we want to be able to get more than one egg. We want to get as many eggs as we possibly can without causing any health issues to that woman. And so that usually involves that woman giving herself some injections. First, she'll be on a birth control pill for about 3 weeks before she can start these injections, and that kind of helps to regulate the cycle. Then about 2 weeks of giving injections to herself, or a partner giving her injections. And then retrieving those eggs from her ovaries is done as a surgery. It's done under general anesthesia. So it is a bit more invasive. Sperm retrieval in most cases is a lot more simple. It usually does not require a surgery, but in some cases of male factor infertility, there can be surgeries involved for the sperm retrieval piece. Once you have eggs and you have sperm, then we want to put them together to create an embryo. And so in most cases for people who are going to be doing genetic testing of their embryos, one sperm is actually injected into an egg cell. And that's this image that you're seeing here is that there's this tiny, tiny, tiny little needle that can puncture the egg cell and insert one single sperm into that egg cell. This is a process called intracytoplasmic sperm injection, or ICSI for short, ICSI. And this is typically required if somebody is doing genetic testing of their embryos. The reason behind this is traditional fertilization. With in vitro fertilization, you would allow an egg to like sit in a petri dish and millions of sperm to be around that egg and kind of first one to make it would fertilize the egg. But the concern here is that the sperm that don't fertilize an egg would then die off, leave residual DNA laying around. And so when that embryo is then biopsied a few days later, if there's still DNA remaining from a sperm that wasn't used, or millions of sperm that wasn't used, that could potentially cause incorrect results with the genetic testing. So when we know there's one egg and one sperm, then that means that that is a much more controlled process and more likely to be accurate results. Oopsies. Once you have egg and sperm together, we hope that results in a successful fertilization. Sometimes it does not, but as long as we get a successful fertilization, that one egg will then kind of do a copy and paste. And that one egg will become it's a single cell. And so that one cell will become two cells. And then those two cells will multiply and kind of copy paste themselves. It becomes 4 cells and 8 cells and so on. Those cells start growing and dividing, and we let those embryos grow. Typically, most genetic testing is done at the blastocyst stage now. A blastocyst is an embryo that is somewhere around 5 to 7 days old. And when you have a blastocyst, you can actually start seeing different layers of that embryo. You can see, I know this picture is a little bit small, but you can see kind of this little blob of cells right here. We call that the inner cell mass, or ICM. And those are cells that would eventually become the fetus or a baby if that embryo were transferred. And then you have the outer layer called the trophectoderm, or TE for short. And those are cells that are destined to become the placenta. So all of this is, kind of getting to that point of like having an embryo available in general. Now, for somebody who is not doing genetic testing on their embryos, if somebody were just doing IVF in general, this timeline, I kind of added in the time for each of those steps. Generally speaking, this could be anywhere from when you add the 2 to 3 months, 6 to 8 weeks, another week here, that could be about 5 months or maybe even more with the, different logistical pieces of that. So it is not a quick process to do in vitro fertilization by any means. I think that's one of the things that I want people to know about going into, if they're considering IVF, would be that it's not something we can just do tomorrow. It does take quite a while to even be able to get to the point of testing an embryo. Okay. With in vitro fertilization itself, so again, not considering any of the genetic testing piece, there are potential side effects and complications, and these, of course, would be reviewed in more detail with the physician that is doing in vitro fertilization. But sometimes if somebody is like overstimulated, their ovaries are overstimulated, that can make them really sick. We call it OHSS, or ovarian hyperstimulation syndrome. IVF has risks of multiple gestation pregnancies. A lot of times that's because more than one embryo is getting transferred. But there actually are higher rates of embryos splitting and becoming identical twins in IVF pregnancies compared to spontaneous conceptions. And so it's still a risk even if only one embryo is transferred, or ectopic pregnancies. So that's where the pregnancy is not in the uterus, it's maybe in a fallopian tube or outside of the uterus somewhere. That can be a risk in any pregnancy, but a little bit higher risk in IVF pregnancies. And then there could be surgical risks or complications. All that to say, most people who do IVF don't have these complications, but of course, these are risks that come with doing this type of procedure and not necessarily with a spontaneous conception. So what are if you do in vitro fertilization, what is the predicted chance of success with IVF? And there's a lot of different risk factors that predict whether or not IVF would be successful for somebody or not. But one of the important things is even if you have embryos available, even if you have good quality embryos, even if you have genetically tested embryos that do not carry a genetic variant that's been identified in a family, it's still not a guarantee of a pregnancy. This is national data from a website called the Society for Assisted Reproductive Technologies, or SART. And this is showing 2019 data, which is currently the most up-to-date data that they have. All IVF clinics have to report data to SART. In general, this is based on maternal age, so the female partner's age. There's about a 40% chance of success with the very first embryo that is transferred for somebody who is under the age of 35. And as you can see, that success rate does go down as the maternal age increases. If we look at all transfers, so some people will have 5 or 6 or 7 embryos. So if we consider all transfers that occurred, those success rates do go up a little bit. So some people don't get pregnant on the first transfer, but maybe the second or the third transfer. But that increases maybe to a 50% success rate for women under the age of 35, and again lower as that maternal age increases. So again, it's not a guarantee, but doing IVF does allow us that opportunity to do genetic testing on an embryo, and then hopefully lower that risk of having a child with a genetic disease, or potentially avoid having to make decisions about a pregnancy when testing is done during a pregnancy. So for many people, they understand that this is not a guarantee, but it's kind of the best opportunity to lower that risk without being faced with difficult decisions. To answer questions about cost, now if we consider just IVF piece, again, not with the genetic testing, we'll focus on that next. The cost of doing in vitro fertilization in the United States on average is around $23,000 per IVF cycle. It does vary by region, but on average, that $23,000, there can be added costs because of this. PGS is a different type of genetic testing, so this is not actually the same as PGT or PGT-M. But on average, you can see that it maybe is lower in certain parts of the country and maybe a little bit higher in other parts. The other piece with that is that a good number of people end up doing more than one IVF cycle, and so they might incur these costs twice or 3 times or even 4 times, as you can see, or potentially more. So focusing then on the PGT aspect of everything, of testing an embryo and how that is done. PGT, again, stands for Pre-Implantation Genetic Testing. So implantation is referring to the process of putting that embryo back into a woman's uterus. That's the implantation part. So before it goes back into the uterus and it's still in a petri dish, we're able to get that genetic test result. We call it PGT-M, and the M stands for monogenic disorders. CMT is a monogenic disorder, monogenic meaning one, or mono meaning one, genic referring to genetic. So a condition that's due to a mutation or pathogenic variant in one specific gene that has been identified in that individual. So, and this refers to all genetic conditions. So essentially what PGTM is doing is it's testing embryos created through in vitro fertilization for that known genetic condition. And as Tara said before, this is something that really does require knowledge of that genetic change in a family. You have to have a genetic diagnosis for PGTM to be an option. If you have a clinical diagnosis but no genetic diagnosis, unfortunately, that's wouldn't be an option unless a genetic test confirms that result or that diagnosis. PGT adds multiple steps to that timeline I showed before. So there's a piece of it where the case is reviewed, genetic test reports are sent to the testing laboratory, and then there is a test that is designed to test an embryo. Sometimes we call it like probe development, but probe really is just referring to looking for that very specific genetic change that is unique to that family. And so this probe design or test development process happens sort of simultaneously as a couple might be going through the test and diagnosis process to ensure they're a good candidate for in vitro fertilization. Once that test development happens, everything is pretty much the same until we get to the end of the embryo development process. And then there's some extra steps that happen to those embryos at that point. So first, with this case review and test development, usually you would meet with a genetic counselor, maybe in person through an IVF clinic, or a genetic counselor that works for a laboratory that does the genetic testing on the embryos. They review the specific genetic change. Certain genetic changes that occur in those genes may be more difficult to test for than others. And so part of this is really ensuring that the genetic change that's been identified in you or your reproductive partner is one that the technology can pick up in an embryo. This, of course, then means that all genetic testing needs to be provided to the laboratory, and again, is necessary for this type of testing. And then the laboratory would accept or reject the case for test development based on that information that they have. 99% of cases are accepted for moving on to the test development process. So most people who have a genetic diagnosis are able to do PGTM. It's a very small percentage of cases that would be rejected for one reason or the other. The test development process probably takes around 8 to 12 weeks, sometimes longer if additional genetic testing needs to be done prior to doing this. So some people, again, don't have the genetic diagnosis. They need to get that genetic diagnosis first, and then submit that to the testing lab. And one of the interesting pieces with PGTM is that it can involve multiple family members. Certainly the laboratory that would test an embryo would need DNA, usually a saliva sample is submitted from each of the biological parents of that embryo. But often they would also need genetic information or a saliva sample from the biological grandparents if they're available for that embryo. And that can sometimes introduce a complication because for some people, they aren't quite ready to share with their family that they are planning on doing genetic testing on their embryos or things like that. But the reason for this really is to make the testing more robust on those embryos. Sometimes testing can miss looking for a specific variant in an embryo. We really have just a limited amount of DNA to work with when we do that type of genetic testing. And so if something were missed, you could potentially get a false negative result. And so by adding in extra family members, they can actually look for other markers that are shared with the parents and then the grandparents Say, for example, you have the mother of the embryo, it has a dominant CMT, and she inherited that from her father. The laboratories actually look for markers that come from that woman's mother, so the grandmother of that embryo. They'll look for markers that match up, and that's just essentially looking at that embryo in two different ways to make sure that the results are correct. So once those embryos complete that development process at that blastocyst stage, so you can see that zoomed in view here, you have again the inner cell mass and the trophectoderm, the outer layer. Somewhere around 5 to 10 cells are removed from that future placenta layer. Those cells then get sent off to the laboratory for genetic testing. And then those embryos are actually frozen while we wait for those results to come back. Embryos can be frozen indefinitely, so it doesn't really matter how long they are frozen. It doesn't necessarily damage those embryos or things like that. But it is a required step of this, because we don't have, embryos won't survive in culture longer than about that 5 to 7 day mark. So when we get results, the embryos will be classified as either being affected or unaffected or carriers, kind of depending on that inheritance pattern. So I just brought up some pictures here of some of those inheritance patterns that Tara was talking about. So this is showing a dominant inheritance pattern, meaning that that individual has one non-working copy of the gene and one working copy. So each of their embryos would be then at a 50% risk of inheriting that pathogenic variant. In recessive inheritance, you have unaffected carrier parents, and then they would have a 25% risk with each conception, that each embryo then would have both variants in recessive inheritance, where unaffected or carrier embryos would not show signs or symptoms. And then in X-linked, this is showing if a male has an X-linked form of the condition where his daughters would be carriers. I don't think I included, sorry about that, included the where a female is a carrier and male offspring would be at a higher risk, but similar to this, just where the mutation is on the X chromosome. So again, those embryos are categorized in each of those in those buckets as far as what the result is, but there is a potential result of an inconclusive result. If the technology didn't work, the quality of DNA in the sample isn't optimal. So that sometimes you go through all of that for no result. The other thing that we usually have a conversation with patients about who are doing this is consider what decisions you would make about an affected embryo or an embryo with no result. For some people, they say, well, the goal is to transfer an unaffected embryo, but if we don't have an unaffected embryo, we would potentially consider transferring an affected embryo if that's all we had. Back to our timeline. So, we already had about a 5-month timeline to get to the embryo development process. The genetic testing adds about 1 to 2 weeks before we have results. And usually then the transfer back into the woman's uterus is not done for another 6 to 8 weeks. Sometimes that's just cycle dependent, scheduling dependent, but that's on average. So again, now considering start to finish, adding the genetic testing piece into this, we're looking at least 7 months for how long this might take. A couple of things to note is that PGTM cannot be used for every genetic condition. So there are just certain conditions that are more difficult to test for, or again, certain variants. Really driven this point home, but we have to know that genetic variant to be able to test for that. Tara alluded to this before, is nothing in genetics is ever 0% or 100%. And so we usually say that PGTM significantly decreases the risk of having a child with that known genetic condition. It never eliminates that risk. There are always very small chances that something is missed with this type of genetic testing. PGTM is not looking for other genetic conditions, so we wouldn't be able to tell if you're only looking for CMT. That means that embryo is not being tested for Down syndrome or cystic fibrosis or other types of genetic conditions or birth defects or things like that. The success of PGTM depends on the success of IVF. And so that's where making sure that you're a good candidate for IVF is really important, because if you were, say, only to have 1 or 2 embryos, then there's a much higher chance that all of the embryos will have will come back with an affected result, versus if you have a better ovarian reserve and more embryos available to test, then there's a much higher likelihood that you would have multiple unaffected embryos available for transfer. And as we were looking at those success rates, even if you have, again, good quality embryos, PGTM is not guaranteeing a pregnancy at all. So there is an additional cost to PGTM, and on average, it would probably add another $5,000 to $10,000 on top of that $23,000 we were looking at before. Again, this will depend on the clinic, the laboratory, and often it might depend on the total number of embryos that are tested. So give or take that already kind of wide range there. And then I just wanted to add a few last pieces in here, that if you do end up meeting with a genetic counselor for a reproductive genetics consult, there are certain things to expect, like discussion of your past medical history, your family history, your motivations for pursuing IVF with PGTM, updating family history, and in this sense, our patient is kind of your future children, and so in that case, we will ask questions about your reproductive partner's family health history to make sure there's nothing on their side of the family that would warrant more genetic testing. And then just providing information on the specific diagnosis, those recurrence risks, carrier testing was indicated. Alternative options kind of beyond doing IVF with PGTM, such as prenatal or postnatal testing options, but really focusing on that, what's involved with the PGT process. And just some tips if you are meeting with a reproductive genetic counselor, just take some time to self-reflect and kind of consider what's important to you and what your motivations are. Talking to your family, one, it's nice to have their support, but also, as I said, that sometimes it actually does, PGTM could involve other family members in needing DNA from them. Of course, including your partner. Some people are doing IVF with egg donors or sperm donors. So, that's why I say if applicable. And then get a referral from your primary care provider, or for females, an OBGYN could refer to a reproductive genetic counselor. Come prepared, have your family history details and any genetic testing that's been done in the family. Your genetic counselor will love you if you come with all of that information. And then check with your insurance. IVF and PGTM is really, really expensive, but some insurance companies do cover some or all of the expense of this. Some states are mandated to cover fertility treatment, not all, so it's good to know what those benefits might look like, or if you have through your employer fertility benefits. Some people will have like a flex spending account or things like that might help in paying for some of this cost, because it is quite expensive, unfortunately. So that's, I think, all I have here. I have a couple of resources for people that might consider doing this type of testing, different support groups on Facebook. Resolve is a great organization just for fertility in general. Fertility IQ has a lot of good information about cost and potential grants and charities. CDC, and then Find a Genetic Counselor to help you find somebody that might be able to see you for this piece.
Sorry about that. I was mute. Thank you, Laura. That was a really insightful presentation. You made it really easy for us layman people to understand, break down all the elements and pieces of the entire process. And I think that's one of the reasons why we really felt a webinar on this topic was so important, is to give people, realistic expectations of the process, because I think most of us know it's going to be expensive and it's going to be hard, but not knowing what steps involved can really become a barrier. So thank you for really bringing us through that as well. And I know, Caitlin, I believe your question was answered regarding insurance. So that's definitely something to look into, whether or not your insurance covers a portion of it or all of it, which would be nice.
And sometimes too, with the insurance coverage, sometimes we will get insurance companies that won't cover the PGTM piece. And I've had some, not always, but I've had some success in writing letters of medical necessity to an insurance company. While this is expensive, I think the cost in some of the treatment and things like that for a child with a genetic disease would probably be more than this testing. So it's a pretty strong argument to make to an insurance company to say, yes, IVF is expensive. Yes, this genetic testing is expensive, but it, in the long run is probably much less than some of the treatments that is involved for an affected child.
Like surgeries and racing, and I mean, yeah, absolutely. I know, Tara, you had some questions.
Yes. Prospective parent need to have a report with their name on it to qualify for PGTM. Can it be in through the clinical diagnosis and inheritance? Most of the time, the laboratories would require a report with the parent's name on it. There is a type of PGTM that is called non-disclosure or exclusion testing, and it's primarily used in like Huntington's disease or different types of dementia cases where somebody doesn't want to know their genetic status. They don't want to know if they're going to develop it. They have a parent who has it, but they just don't want to know for themselves. But they also want to make sure that if they do have it, that they're not passing that on to their children. And so there is a way to do testing if you don't want to know your genetic status. I haven't seen that specifically in CMT or other hereditary neuropathies. It's usually more the dementia cases that we would do that for, but that would maybe be the exception if where it wouldn't be needed for the prospective parent. And then for IVF, is the male always required to be tested? I guess genetically tested, if they are the ones that have the clinical diagnosis, then they would need that testing. If the female partner is the affected one, they would not need the genetic testing for CMT to prove that they're negative. It's kind of assumed that they would be negative. If it's more referring to just the testing and diagnosis of the IVF workup, then they would need the infectious disease testing, the sperm testing, things like that. So I don't know if I answered your question, Tara.
You did, yes. I was asking about the IVF pre-screening. So yeah,
Perfect.
thank you.
One thing I had a question about as well. During the pricing segment, you spoke about the pricing per cycle. Can you have multiple embryos in one cycle, and what determines what's included in one cycle? Is that the amount of eggs that are released, or?
Yep. So yes, one IVF cycle is one egg retrieval, essentially. So we get as many eggs as we possibly can. So if you have 30 eggs, we know that not all of the eggs will fertilize normally. If you started with 30 eggs, you may have somewhere around 10 embryos to test. So that's one IVF cycle in that case.
Okay.
And so hopefully you have embryos then available out of those 10, but if not, then you move on to do another egg retrieval and as many embryos as you get from that egg retrieval. So Good question.
Understood. Okay. Yeah, that makes sense. Okay. Do we have any other questions for our genetic counselors here?
I wanted to add to Caitlin's question, what does checking insurance look like? I always recommend that you look at your evidence of coverage booklet. And that goes through all of the CPT codes, which are the codes for each procedure. And it might even tell you, if we cover this, these 3 criteria need to be met. And that kind of helps you at least get some idea, but it will still be very confusing and you will have no idea what CPT codes to look for. So would also help to call your insurance company to see if they can kind of break that down for you. But I have a lot of patients that call their insurance company and their insurance company has no idea what to tell them. So
that's
yeah,
reassuring.
I have similar experiences with that. And I think what you said, Tara, too, is important with like certain criteria need to be met. I've had some unfortunate cases where I've had insurance companies say that they would cover PGTM. They cover the genetic testing, but they won't cover IVF because the couple's not actually infertile. They don't have an infertility diagnosis. They're doing IVF to do genetic testing. And it's, it's like, well, you can't do this testing without IVF. But if you don't need IVF to get pregnant, then sometimes they won't cover the more expensive piece of all of this anyways.
Yeah, those insurance companies are so much fun to deal with. Keelan said thank you. So yeah, I know a lot of people watching this webinar are still in the very early stages. Maybe they're still trying to figure out what type of CMT they have. Not everyone has insurance. We do have some other resources. If that's the case, please email us at the top of the chat box. It's our general email box that goes to myself and Courtney, and that's info@hnf-cure.org. So we will do our best to connect you with the resources to answer any of your additional questions regarding testing and where to go for that, depending on what state you're in. And like I said, this is going to be a multi-part series, 3 parts. We understand it's a really wide topic. Outside of IVF, what does a pregnancy look like for a woman who has CMT? What are the risks involved? What should we try and do? What should we try and stay away from? What are some of the unique nuances of pregnancy and CMT? So we're going to be diving deeper into that, as well as speaking with a panelist on the topic of surrogacy and hearing a little bit about her story and her journey, her CMT story. She has one daughter with CMT. Her late husband had CMT, and then they decided to do surrogacy for their second child. So I think it's just really powerful to hear from somebody's story, what to expect, what was involved, and how they made it through their journey together. So thank you again for everyone for joining us. We look forward to continuing the conversation with Laura and Tara. Thank you so much for your time this evening and your expertise. We are very, very much grateful for that. And
I have one more question for Laura, actually. Is it possible in doing the IVF screening that you can determine you're infertile, or does that have to be a lot of attempted natural conceptions that fail?
Yeah, so some people would say they're doing the fertility workup, and then all of a sudden the male partner learns that they have very low sperm count or something like that. That could be, then you get an infertility diagnosis.
Okay, so that would qualify for the insurance coverage. Yeah. All right, well, thank you. Yeah, and if any other questions pop up along the way, feel free to watch the webinar with your partners and family and friends. And we look forward to hearing from you. All right,
Thanks,
well, thank you so much, ladies. Have a great evening.